A very good evening to one and all. Myself, Dr. Vasundara Jagannathan, Medical Director from Sri Chakra Fertility, and Dr. Sindhuja Srinivasan, the IVF Lab Manager and Academic Coordinator of Sri Chakra Fertility. We extend a wholehearted welcome to all the delegates who have joined here for the Scale Master Class Series. We have just initiated this masterclass series in embryology, and couple of months we've been having this masterclass series in various topics. This has been delivered by visionaries in the field of reproductive medicine with the sole vision of propagating knowledge and updating ourselves in the field of reproductive medicine so that we can do the best to our patients. And we extend our sincere thanks to all the visionaries and teachers and seniors in the field of reproductive medicine who have agreed to, be a part of this masterclass teaching program. And Sindhu, can I just see the PowerPoint? So just a few glimpses of what masterclass series we had in embryology. We initially started with oocytes, everything about fertilization, which was delivered by Dr. Sujata Ramakrishnan. And then we had about implantation, and then we had all about oocytes. And this is attended across India by the clinicians, embryologists, students, fellows, and close to 300 to 350 delegates every time attend this program. And your positive feedback has, given us a drive to do more and more. And with this, we also thought that we will do masterclass series in advances in ART as well. And Sanjeeva Reddy sir has consented to start this series in advances in ART for us. And we are greatly indebted and grateful for you, sir. At the outset, sir needs no introduction, but still in conferences we rush through the series slide of sir, but here I don't want to rush through. I am proud to say I am a student and he has trained generations of students in this field of reproductive medicine. And sir is a professor of Department of Reproductive Medicine and Surgery at Ramchandra Medical College and University. He started the first super specialty course, that is MCH in Reproductive Medicine and Surgery in India. He's been awarded with various awards, the most prominent one being the V.C. Roy National Award by the President of India in 2015, Distinguished Faculty Award at SRIHER in 2020, Champion Visa Award, IVF Icon Award, Lifetime Achievement Award, ISAR Dr. Durusha Lifetime Achievement Award in 2024 at Bhubaneswar, CIIM Lifetime Achievement Award, the Bhishmacharya Award, Dronacharya Award. In fact, these awards make me get goosebumps and really, want to do Guru Vandanam to you, sir. Expert panel member to Medical Council of India to formulate syllabus and minimum eligibility criteria for MCH in Reproductive Medicine and Surgery. He's also a specialist board member in Reproductive Medicine for the National Board of Examinations. He's expert member to the NTR University of Health Sciences, Andhra Pradesh. He's a governing council member of Indian College of Reproductive Medicine. He's a past president of TAPISAR. He's a past president of OXY, organizing secretary and chairperson of AICOG, Yuva ISAR, and Embryology ISAR conferences. And he's a mentor and backbone for many of us in the field of reproductive medicine. With this introduction, I would request Sanjeeva Reddy sir to share the advances in recurrent implantation failure to all of us, both evidence and experience. I request all the delegates to take part in this masterclass series, actively interact, ask questions, and then, we get to learn from each other. Thank you so much. Welcome you, sir.
Thank you, Vasundara, for a kind introduction, and also Dr. Sindhu for coordinating with this and inviting me to share some of my thoughts with you all today. Today I'm going to speak on advances in the diagnosis and management of recurrent implantation failure. So all of you know, the success rates of ARTs have improved steadily since the first live birth from IVF in 1978. At that time, the implantation rates were less than 10%. The early years have now increased to as high as 65% in several IVF programs with transfer of euploid blastocysts. However, 35% of euploid embryos transferred to an anatomically normal uterus still fail to implant. Implantation is a critical step in reproduction. The success of this step is dependent on a competent blastocyst, a receptive endometrium, and successful crosstalk between the embryonic and maternal interfaces. The implantation process includes apposition, addition, and invasion. Implantation is considered successful when there is ultrasound evidence of an intrauterine gestational sac. Implantation failure is considered if there is no lack of ultrasound evidence of intrauterine gestational sac. Implantation failure may occur very early and during the attachment or migration stages. There is no objective evidence of pregnancy. Even if you do the blood or urine test, it will be negative. It may also occur later on following successful migration of the embryo. HCG may be detected in the blood or urine, but the process becomes disrupted prior to the formation of intrauterine gestation sac. It is clinically referred to as biochemical pregnancy. In ART, intrauterine gestation sac is detectable by USC 3 weeks after oocyte retrieval or 5 weeks after gestation. From the clinical point of view, the term implantation failure refers to two different types of situation. There is no evidence of implantation. That means no detectable HCG production either in urine or blood. There is evidence of implantation. That is, HCG can be detected, but did not proceed to beyond the formation of a gestational sac visible on ultrasonography. There is no, if you take the definition, there is no accepted formal definition for recurrent implantation failure. That's the main problem. So, RAF as the failure of clinical pregnancy after 4 good quality embryo transfers, at least 3 fresh or frozen IVF cycles, women at the age of 40. SRIHER defines RAF as when more than 3 good quality embryo transfers or 10 embryos in multiple transfer cycles without achieving a clinical pregnancy. An international survey of clinicians and embryologists showed that the majority defined RIF as a failed embryo transfer with 3 cycles, both fresh and frozen, with no agreement on the cutoff of upper age. The instance, due to variations in the definitions for recurrent implantation failure and biochemical pregnancy, there is a scarce data that accurately represents the incidence or prevalence. In spontaneous conception, it is estimated that around 30% of pregnancies are lost before implantation and 10% of clinical pregnancy losses. In ART, it is varying from 1 to 5%. That means less than 5% will have RIF. What are the risk factors for IF? Maternal age. As all of you know, when the age advances, the pregnancy will be less. Same way, when the BMI is high, that is particularly more than 30%, there will be implantation failure will be more. And smoking also affects the pregnancy. The toxins liberated, it can affect the corpus luteum and implantation failure will occur. Stress, this is one of the important causes. It is the cortisol that is also known as stress hormone. When there is stress is there, 2.7 times greater chance of miscarriage. What are the causes of recurrent implantation failure? As you know, mainly the gamete and embryo. Next, uterus that contains the endometrium and some associated disorders like hydrosalpingus or immunological factor, thromboembolic condition also may aggravate for these problems. We'll discuss each one separately. When you take the oocyte quality, as we have seen, whenever there is poor response to your stimulation, or when you are estimating the ovarian reserve test, low antral follicle count or low AMH or high FSH, that shows that the decreased ovarian reserve is there. These patients we can accept there will be poor quality oocytes. And also, if there is patient is maternal age is advanced, there will be definitely the poor quality oocytes will be there. This is because of increased chromosomal disjunction, increased aneuploid embryos, decreased mitochondrial membrane potential, increased mitochondrial DNA damage. This all leads to poor quality of oocytes. And also, if you give aggressive stimulation, there will be poor quality oocytes and there will be also high fertilization failure. That's why you should judiciously use the individualized stimulation, not for everybody giving more amount of these things. And also next, Apart from the egg, sperm also is important. Here, there will be, whenever there is a poor quality sperm is there, then the embryos also will be poor quality. And what we will be doing, conventional semen analysis, it do not reflect semen quality. So genetic tests are more useful, like this gives us the epigenomic integrity, all the things it will give, because it is important for fertilization and normal embryo development and successful implantation. Next, and DFI, increased DFI, there is modest impact on IVF pregnancy rate, but here still we are not sure whether it is affecting implantation. There is definitely there is increased risk of marriage miscarriage. So still we are not clearly established that increased DFI will affect the implantation. Next is parental chromosomal anomalies. That is the one of the other things. There will be, if there is balanced translocation, it leads to defective gametogenesis that can lead recurrent pregnancy loss. In RIF couples, if you do the karyotyping, there will be 2.5% chance of carrying those patients with balanced translocation. Another, when it comes to the uterine factors, there will be congenital uterine anomalies and acquired uterine anomalies. So this can affect endometrial receptivity by infertility or recurrent pregnancy loss. Like suppose if there is uterine septa is there, it can lead to first and second trimester miscarriages and cause infertility. It also may contribute to RIF depending upon the where it is implanting. Next, when you go for the acquired causes like submucous fibroids, endometrial polyps, intrauterine adhesions contribute to recurrent RIF. The frequency of, if you evaluate this patient, the frequency of unrecognized intrauterine pathologies in patients with RIF varies between 25% to 50%. You can see like that. So evaluation of these patients is important to exclude this problem. Next is, whenever there is submucous fibroids are there, submucosal and intramural fibroids that distort the endometrial cavity are associated with decreased pregnancy and implantation rates in women who attempt to conceive spontaneously or if you subject them for IVF. Hysteroscopic resection of the submucous fibroids alone double the cumulative clinical pregnancy rate. Whenever you come across with this, if you remove this one, that problem can be solved. Next is, there are some problems will be there. Intramural fibroids, but it may not be distorting pregnancy. Here, if the size of the fibroid is more than 4 centimeters, definitely it is going to affect the implantation and pregnancy rates. But some studies are showing those patients, even if it is smaller than 4 centimeters, it is not distorting also, it can affect the cytokines released from these fibroids can affect the implantation rate. But the studies are showing, can we do routinely for all patients whenever you come across whatever size may be the fibroid, if you do the myomectomy, in those patients they have seen there is no significant increase in the clinical pregnancy rate. So you have to use your experience to do this one. Next is endometrial polyps. This is also one of the problems for implantation, but removal of the endometrial polyps has been found to, there will be increased spontaneous pregnancy rates also will occur. Even if you go for the IVF also, there will be doubling of the pregnancy. Whenever come, if you see the polyp, whatever size it may be there, you have to remove. Next is intrauterine adhesions. There are many causes. One of the things is vigorous curating or following MTP or DNC like these patients. So whenever there is additions, intrauterine adhesions are there. So many times by ultrasound itself, we may not be able to make out unless if you use the Cellen's infusion sonography, you can make out. Hysteroscopy, we can make out. When you remove like that, these things, the pregnancy rate definitely will above. In RIF patients, if you do the hysteroscopy, there is 8.5% of patients will have intrauterine adhesions. Another problem in the uterus is the adenomyosis. As you know, it affects the junctional zone. It has got greater impact on implantation than the fibroids. Treatment also is very difficult Even if you have to go for the surgery, you have to remove some of part of the wall of the things. The pregnancy rate definitely will be less due to decreased implantation of these patients. Next is hydrosalpinx and RIF. Here, whenever there is hydrosalpinx is there, the live birth rate will be 50% less when compared with the patients without hydrosalpinx. By removing this, that is salpingectomy, other thing, it improves the pregnancy rate automatically. So that's why whenever you are coming across the hydrosalpinx, you should remove. There is one problem is there. Previously, they have seen some patients, if you remove the salpingectomy, it can affect the vascularity of the ovary. There may be decreased ovarian reserve may be there. For that, you can go for the other types that we'll discuss in the treatment part. Next, immunological factors. Until now, there is no consensus on whether or not immunological investigations are useful and whether immunological treatments is of benefit. One thing is the role of nature killer cells in RAF, and this is also is controversial. Thrombophilic conditions like acquired and hereditary also will be there. This also can affect the, mainly it affects the recurrent pregnancy lot. RAF, there is a doubtful thing. So what are the investigations you can do for these patients? Gamete and embryo factors. For that, we have to assess ovarian function test. Next, sperm DNA integrity testing is the sperm analysis is normal, and karyotyping of both the partners. When you diagnose the uterine factors, so ultrasonography, HSG, sonohysterography, hysteroscopy, finally the gold standard, the combined histolaparoscopy is the best. If there is hydrosalpinx also, we can diagnose by transvaginal scan itself or HSG or during laparoscopy. If you have doubt something, it definitely clears.
Sir, yeah, shall we have a small break now, sir? We'll just have a small quiz.
Okay, okay.
So everyone, I'll just be sharing a small quiz. It will be visible on your screen now. So all of you can attempt. There is no right, wrong. It's just to see, evaluate how much you have listened and you're paying attention, and just for all of us to learn. So there are 5 questions. All of you can attempt the questions. And once, we'll just give 5 minutes for this. After that, I will display the answers.
And this is totally anonymous, and it is no right or wrong. It is just for us to just learn and understand the whole thing. That's it. I request all the delegates to please take part.
In the next questions.
If they scroll down, they can see. Yes, sir. Vasundara ma'am, you're also attempting. Are you able to scroll down and see the questions?
Yeah.
Okay.
You can scroll down. I'm looking like, quite a bit of active participation from many.
40% have participated so far.
Yeah. You have another 2 minutes or 3 minutes?
Sir, exactly for the questions, your presentation had answers, sir. When I was...
I can also answer. I will get praise, Sindhu.
Yes, sir, definitely, sir.
50%.
We'll just 50% have participated. I encourage everyone to participate. There is no right or wrong. You can just take part. We'll give 1 more minute, ma'am.
Yeah, this last. Since you gave a clue, the answers are in first presentation. I think after the second half, next 5 questions, everybody will be like 100%.
There'll be more attention. 4 minutes, 15 seconds. At 5 minutes, I'll close it. 60% have participated. Usually, sir, I'll ask very easy questions, sir. Everybody will get correct answers. Now, I don't think you can see answers, but I can see how everyone is answering. And I display the answers. Okay, ma'am. 5 minutes is up. I'll end the poll now and I'll share the results. Is it visible for everyone?
Yes.
Okay, so the first question is, in spontaneous conception, what percentage of pregnancies were lost before implantation? So the correct answer is option C, 30%. 32% have answered correctly. So for the others who have answered different answers, so 30% is the right answer. The true rate of RIF is likely to be in the range of, the correct answer is 1 to 5%. So majority, 39% have answered that. The following were all high risk factors for RIF except, so the correct answer is alcohol intake. I think majority have followed, 60% have answered it correctly. The frequency of unrecognized intrauterine pathologies in patients with RIF, the correct answer is 25 to 50%. So 41% have answered. Majority have told 10 to 15%, but the correct answer is 25 to 50%. The size of non-cavity distorting fibroid that can adverse effect on implantation and pregnancy rates in women undergoing IVF. It was there in sir's slide. Majority have answered it correctly. It's more than 4 centimeters. Okay. I think you're all able to see the correct answers also now.
They are listening to my lecture, Sindhu.
Yes, sir. We're all sitting in the edge and listening, sir.
Can you close this, Sindhu? Can you remove this?
Yes.
Okay. When it goes to the management of recurrent implantation failure, you should multidisciplinary team approach is important. So in this team, you should have experienced fertility specialists, senior embryologist, reproductive surgeon, and counselor. So in any decision you take, lifestyle changes management is important. In addition to a review of investigation and treatment to date, clinicians should discuss and advise as to lifestyle changes which could improve the likelihood of treatment success, like smoking, alcohol, sedentary life, exercise, all these things you have to tell them important that will help like that. One of the important thing is smoking. So smoking can affect so here it can affect the patients. So in female also like increased gonadotropin requirements. If you go for the IVF also, you will get very less number of oocytes, higher number of cancer cycle because number of oocytes will be getting less because it is affecting the reserve, lower implantation rate, more, and also the fertilization failure also will be occurring. Male partners also it can adversely affect the sperm counts and motility and morphology, and it increases the DNA factor also. Next is body mass index. This is also one of the important thing. So unless if whoever is there overweight and obese patients, so it can affect all the aspects. The first line treatment is diet. So like you have to reduce the calories. That is important. Next is modification and regular exercise important. Some of the people will say, why I have to do the exercise, whether I can reduce the diet alone. So there is two types of fat will be there, peripheral fat and visceral fat. Visceral, if you do the dieting, it will affect only the peripheral fat. Visceral fat is important because that produces the uh, insulin resistance, other problems. So unless you do the exercise, that cannot be controlled. It cannot be reduced. So, and always some people say, I can do my exercise. That's not important. So, structured weight loss programs involving behavioral modification is important. So, with that, better to go for a gym, other things. So, underweight is there. They have to gain weight, obese, lose weight by diet and exercise. And structured weight loss program is better always. Next is in addition to lifestyle changes, if it is not responding in spite of your uh, dieting and the exercise, we have pharmacotherapy. One of the drugs for a long time we are using is the Orlistat, 120 milligrams 3 times a day. At least 3 months we have to use to see whether there is an effect is there. There are some latest drugs has come. Still, it is not approved by FDA. We have to wait and see. Next is the patients are not responding to pharmacotherapy and they're morbidly obese, and there are some comorbidities there. For them, we can use bariatric surgery. After surgery, at least a minimum 1.5 years to 2 years we have to wait, and the for conceiving. Okay. Next is alcohol consumption. This is also can affect. So like it can increase the risk of miscarriage. It may not that much affect the implantation. It can lead to premature birth, low birth weight. So if the people cannot control, so they can reduce 1 or 2 units once or twice a week. That is enough should be there. Infertile patient better always to abstain from alcohol intake. Next is ovarian stimulation protocol, whether you have to change. If the stimulation is satisfactory, no need for us to change the stimulation protocol. If the oocytes you got is suboptimal, then increase the gonadotropin doses. So some people may ask whether agonist protocol is better or antagonist protocol. The studies are showing there is no difference. Whichever they take, the other no need for the result will be same only. Some if the patient's age is more than 35 years, adding up LH is important. And in case of endometriosis, adenomyosis is there. If you use the ultra long protocol, it may be used. Some studies are showing instead of IVF, if you go for the ICSI in these patients, there will be better fertilization rate. Next is immunological therapy. There are so many drugs are used. Whether if it is like empirically, many people will be using aspirin, corticosteroid, granulocyte colony stimulating factor, intravenous fat emulsions, intravenous immunoglobulins, adalimumab. These are all the things they will be using. We'll discuss some of the things. Glucocorticoids, Here, actually, many people they'll be using the steroids like prednisolone and other things. It is not that much useful actually routinely. It is having its own problems, so we should be careful before using this one. Discuss with the patient, take consent, then only you can use. But in some specific patients, specific subgroups of patient, it can help. Next is intravenous immunoglobulin. So it it can protect the fetus from the maternal immune system by promoting. This is also we should not use for everybody. Only some patients we can use. So it can alter the TH1 and TH2 ratio. It can help those patients. Next is same way if you use combined application of intravenous immunoglobulin, aspirin, the heparin could increase the pregnancy rates and total blood drug cell proportion patient with RAF compared with patients using only aspirin and heparin. There, if you can use the dose will be 200 to 500 milligrams per kg body weight. This we can give 7 to 24 hours before embryo transfer, then every 3 weeks. So we can give this thing. Then there is some studies are showing better thing. There are some other drugs like cyclosporin. This is also not for every patient. Routinely, it's not advisable. Only some cases. So it is showing there will be improvement of implantation, unexplained RAF, not in for every patient. Routine administration is not recommended. Next is intralipid. It is also large-scale studies are required to explore the effects and safety of intralipids in RA patients. So it can help patients overact. Whenever there is overaction of the natural killer cells are there, intralipids are helping. So it is not for every patient. You should individualize when you are using like lymphocyte immunization therapy. This is also some papers are telling routine is not advisable. There is insufficient evidence to recommend LIT in patient with RIF. We should be aware of the possible complications such as infections, autoimmune disorders, and formation of irregular antibodies. Next is one more drug that everybody will be doing routinely. So here the studies are showing there is no effect of routinely supplementing aspirin to these patients for two things. We should be very careful when you are giving. Next is low molecular weight heparin also. So this is also is not routinely, if you have that APLA, other things they have given, but some of the studies are showing in RA patient, if you give this one, significantly improve live birth rates and reduce miscarriage rates. So low molecular weight heparin may be a potential intervention for patients with RAF at a dose of 40 milligrams per day from the day of oocyte retrieval or embryo transfer to 8 to 12 weeks of gestation. Next is intrauterine infusion of human chorionic gonadotropins. So this is also showing this is administration 72 hours before embryo transfer at a doses ranging from 500 to 1000 IU. They have given some patients are showing improvement, but definitely you cannot say you discuss with the patient if she is willing you can transfer these things. Otherwise, routine administration is not necessary, not advisable. Some subgroup of patients they are getting benefited. Next is granulocyte colony stimulating factor. So existing evidence suggests minimal harm and potential benefit to this therapy in indicated patients with unexplained recurrent implantation failure. This is also there is showing there is 2.63% increase in times increase in for implantation rate. This is also, but definitely we cannot say. Next is platelet-rich plasma. This is also like some people are using But we need, that's all. The main problem is the number of patients in that studies is very less. So we need bigger studies, the RCTs with many patients. Then a bigger sample size, then we can say definitely it is going to help. Letrozole, there is some patient improved live birth rates in RAF patient receiving letrozole. Still, we need further studies for this. Growth hormone, this is also like helping some patients. Studies are required. Actually, Professor, like dydrogesterone used in IVF protocols may have a significant role in altering the TH1 and TH2 ratio. That way, we'll be giving supplementing these patients. Improving pregnancy and live birth rates among patients with RIF, mainly when started in the luteal phase. But for this also, more studies are needed to support this thing. Definitely, for every patient, you can give like that. Next, sperm DNA fragmentation. Here, usually, see, previously it is only they were telling like that it affects only the miscarriage rate is more. But latest thing it is coming, it can affect the implantation also. So when suboptimal spermatozoa are considered to be a contributor cause of RIF, several treatment options may be considered in this patient. One of the things, oral accidents, we can give for this patient 2 to 3 months. Then second is sperm selection is important. Annex and V columns, all this type of thing, IMSI like that we can try. Finally, some people are trying instead of the ejaculated sperm, you can go for the testicular sperm with that. So the amount of DNA fragmentation index will be lessened in this patient. Next is how to improve the embryo quality and how whether we can select the good quality embryos. So there is, we can use the time lapse. Some of the people are telling, but the studies are showing this is not that much helpful. So here we have to review again this patient, like age of the woman, AFC, that means ovarian reserve test, number of oocytes retrieved, the proportion of immature oocytes, all these can also will affect for this patient. We cannot definitely say it is going to improve. By supplementing additions, other things, some um, literature is showing there is improvement, but we cannot say definitely it is going to improve the thing. Next is, as you told like that, blastocyst transfer instead of going following the cleavage stage transfers that can help for these patients in women with RIF. So we can try blastocyst transfer in these patients if we have sufficient number of embryos are there. Next, assisted hatching. This is also regularly we cannot do, only some cases, but ASRM says it is not such that it does not support the routine application of assisted hatching in all IVF cycles. But in some patients, like poor prognosis patients, including those with a history of 2 or more unsuccessful IVF cycles, poor embryo quality, and the older patients, it will be useful. Next is PGD. The value of pre-implantation genetic diagnosis in RF is controversial. There is no evidence to suggest that the embryos produced by women with RAF are more likely to be normal. The frequency of aneuploidy, around 67% in embryos from women with RAF, similar to that the frequency in women without the condition also. So normal itself, there will be 64%. Definitely by doing this thing, we cannot improve the pregnancy rate that much. Further studies are required to confirm whether or not routine PGD using microarray CGH is beneficial in women with RIF. Metabolomics, this is also one thing we are doing. Embryo transfer, if you do ultrasound guidance, definitely there will be increased pregnancy rate will be there instead of doing blindly without ultrasound thing. And sometimes you can do the uterine quiescence also, like pyraxicum, atosibone. This will try help like that. Ultrasound guided is always important. Then I told you like these are the drugs also we can use to reduce the uterine contractions. Next is if you do the trial embryo transfers, you'll have like unexpected things like internal loss. It may be difficult like that. Then instead of that one, if you do the trial transfer before, then it will be useful. Particularly if the particular patient had some cervical surgery previously, so it will be there. Next is sequential transfer. So here what we'll be doing like that. In this is not that much useful, and the interval double transfer did improve the outcome in women with the repeated IVF embryo transfer failures. So there is little benefit if you go for the interval double transfer. So double embryo transfer may be a benefit, but carefully designed randomized control trials are required to confirm its value, if any, in women with RIF. So then when it comes to the uterus, histoscopy, we can diagnose the intracavitary lesions, submucous fibroids, endometrial polyps, uterine septum, intrauterine lesions. This all can be corrected by using the histoscope. So myometrial pathology, intramural fibroids, we can remove with laparoscopy or histoscopy. Adenomas also we can do the some of the surgeries or separation with GnRH. And other problem what will be facing the thin endometrium. So the thin endometrium causes that it may be inflammatory, iatrogenic, or idiopathic. So the treatment options available is extended estradiol therapy, HCG priming the follicular phase, mid-luteal GnRH agonist, tamoxifen, aspirin, sildenafil, granulocyte colony stimulating factor, platelet-rich plasma, stem cell therapy, endometrial fertility, or vitamin E. These are the options available. So next, when it comes to the hydrosalpingics, I told you already, salpingectomy, if you do, the pregnancy rate will be doubled. But one problem they have come across in some patients, so it can, unless if you take precautions, it can affect the uterine supply of the ovary, so there will be decreased ovarian reserve. For that, we can do other things also, or sometimes these hydrosulfings may be the additions we may not be able to remove. There you can go for the clipping of the medial part of the tube, or what we are doing regularly is, so any patient, if you tell like infertile patient, I will remove a tube, that patient won't be happy. So we can go for the other option is salpingostomy. So here we are opening the tube, linear salpingostomy, so that fluid won't be staying there. So it is not going to, that endotoxins won't affecting the implantation failure. So without removing tube also we can do and clip the medial part so that it prevents the chance of ectopic pregnancy. Next is endometrial scratch. So it was very popular 4 or 5 years back. Now it is proved studies, there is no use at all. Next is empirical therapies like aspirin, heparin, we discussed already. So no benefit of use in IVF programs. Heparin therapy is not justified on the basis of existing data unless something is there. Nothing is working for this patient, then we'll have gamete donation if there is problem with the gametes, and surrogacy if the patient is having the fetus is adenomatic, not responding to therapy, intrauterine additions are there. That's also no. Next is endometrium is very thin and it's not responding to all the treatments what I told you previously. If it's not there, then we'll have finally option is the surrogacy. In summary, RAF should be defined as the failure to achieve a clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycles in a woman under the age of 40 years. Women with RAF should be offered appropriate investigations to rule out an underlying cause for the repeated failure. The main treatment strategy in couples with RAF is to improve the quality of the embryos transfer and the receptivity of the endometrium. Hysteroscopy should be carried out to exclude any intrauterine pathology. It has been shown to improve outcome. But routine hysteroscopy just before IVF is not helping. Suppose the patient had some problem, once it failed. Second time, if you do, even if there is no pathology, definitely the pregnancy will improve after hysteroscopy. Appropriate investigation should be carried out to exclude hydrosalpinx, and it has been shown to reduce implantation rate, increase miscarriage rate, and reduce live birth rate. Removal of hydrosalpinx has been shown to improve the outcome. Submucosal fibroids have been shown to reduce implantation, pregnancy, and live birth rates. Removal of submucosal fibroids improves implantation rate. Endometrial polyps should be removed. Although there is no data on its impact on women undergoing IVF, it has been shown to improve outcome. See, sometimes we'll have problems. See, before starting the cycle, if you diagnose whatever size it may be there, so better to remove, then you can go for the stimulation and transfer. Sometimes what will have problem when you're preparing the endometrium for the transfer, that time suddenly you will find out there is a polyp. In this condition, we can discuss with the patient. It may affect, if the size of the polyp is less than 1.5 centimeters, it may not affect the studies are showing. You can explain to her if she wants to proceed with the transfer, you can proceed. Otherwise, cancel the thing. Then you can remove the polyp. Then you can go for the transfer. Uterine septum, definitely it will leads to miscarriage rate. It is almost 80% miscarriage rate will be there. If you remove, it will decreases only 20% miscarriage chance will be there. That's why always better to, if the patient is having RA, definitely have to remove this one. So in case of endometriosis and adenomyosis, use of ultra-long protocol may improve outcome in women with endometriosis and adenomyosis. 20 years before, almost all the studies, they will say ultra-long protocol. In my experience, after the starting of the antagonist protocol, if you give the normal responder or hyper responder, if you go for the ultra-long protocol, it's okay. If there is some decreased ovarian reserve there, if you give this one, there will go over suppression. You may not get any oocytes or very few oocytes. That's why just go for the anti protocol, do the oocyte retrieval, please it, then you suppress, then you can go for the frozen embryo transfer. That is better. Intramural fibroids, even though they say 4 centimeters, there are some studies are showing, even if it is less than that, the inflammatory cytokines released from the fibroids, it can affect the implantation. So that if you are going for the patients, better to remove the fibroid, then you can go for the IVF. Intrauterine adhesions, definitely it is better to remove, then it will, pregnancy will be improved. A multidisciplinary approach should be adopted in the management of RF5. Empirical therapy should, whenever possible, be considered only in the setting of carefully conducted clinical trials. But whatever you are doing like that, you explain everything to the patient, take the consent in writing, then only you should give. These are the references. Thank you for your vision.
Thank you, sir. I will project the next set of questions and
then we'll go for the Q&A. There are a few questions in the chat box.
yes.
Yeah.
Is it visible?
Yes.
Sir, there are a few questions in the chat box, sir. First question is, what impact does immunological therapy have on the health of the individual on the long run?
As you have seen, there is a lot of problems are there. If you take like bone also, it can protect avascular necrosis of the femur. That's also can neck of the femur that can happen like that. This type things are there. It will reduce the immunity also. Patients can develop infections, other things are there. That's why when you are starting this thing, short the courses, it may not affect much. If you are giving longer time, then it can definitely affect. That's why you should be very careful. When you are giving steroids, always explain to the patient with her consent only we can give. And it is not showing that much important. Unless they have some immunological problem, it is not advisable to go for the drugs.
So the next question is, in what subgroup of patients will steroids help in your experience?
If there is if you found there is something like anti-nuclear antibodies, the type of thing, autoimmune diseases, there it will help. Otherwise, routinely normal patients is not advisable to give. See, many patient prescriptions, if you see like that, there won't be any like investigation showing there is no abnormality. We'll think there may be some pathology like that by supplementing the steroids along with other drugs, so they can improve like that. But it studies all showing it is not improving.
Chat box, that's all, ma'am. Vasundara, ma'am, you want to add anything?
Two questions here. So one is you were mentioning about some testing of sperm genetics also. What genetic tests are recommended for the sperms to suggest that that could be a factor in RAF? Any genetics test specifically for the man before we proceed, sir?
Sperm manipulated also we can check. That is also one of the things. It is not routinely tests come out like that. So, but it is studies are going on like that in the laboratory level. Hope like for testing the oocyte like that. We are not giving like for male also we won't give. He will be sitting in one corner in the hospital like that nowadays. And we are thinking everybody thinks by doing a ICSI we can come across all the male problem. That's one thing like that. Now there is people are recognizing male also is equally important. That's why they are giving some things. Whatever you take, IMSI, other things also we are giving some importance and we are going like that. Probably after some time we'll get some more things. So,
Okay, sir. And also in cases of recurrent implantation failure, protein hysteroscopy and screening for chronic endometritis is must, sir.
yes, see, we have done a study in Ramchandra for all patients, whoever is coming to the with infertility. We had taken just endometrial biopsy for by histopathology we cannot diagnose. Immunohistochemistry CD138. 27% of patients they are having this thing. And for these patients, we had for IVF patients also we had done by whenever it is coming positive, the drug of choice is the doxycycline, 100 milligrams BD for 14 days. You just give like that, and again we have second time also we have taken the biopsy. Some patients, see usually with this around 85 to 90% of patients will be cleared. And some patient, whoever is coming positive, for them, we can go for the ciprofloxacin, tindazole, another course like 2 weeks, like this, or azithromycin also we can go these things for these patients. When we did the study, after that again we went for the transfer. So it is those patients treated and it became negative. The pregnancy rate will be same as those patients without chronic endometritis. Those patients who are having persistent endometritis, the pregnancy rate is very less.
And also, what is the role of endometrial receptivity studies or endometrial microbiome in RAF, sir? Should we?
The endometrial receptivity array, see now it has previously we are using. Nowadays, the one problem with that is each cycle will be different. Even though they have given pre-receptive, receptor, post-receptive, that's what each cycle will be changing. And also now it has come like that. There is no use at all that one like that. It's not helping. That's why going for the era is not useful. Another thing you asked something.
Microbiome, sir.
Microbiome, this is the latest thing. It is coming like that. It can affect. We need some more studies definitely to say for every patient. Maybe like after some time we may do that also like a thing.
So can we routinely give some probiotics? There are so many pharma companies with uterine-specific probiotic, vaginal probiotic, because they are desperate in RIF cases. We really don't know, and we don't have much data. So can we give at least routinely probiotics in RIF cases, sir?
You always discuss with the patient. So until it is not doing any harm to the patient, like if you take steroids, if you give it, definitely it's going to affect the patient. There you should not give. This type of things, it may help it or it may not help like that. Then we can give these patients. After discussing with the patient, just if she's willing like that, always take the consent. Then only we should give like. Otherwise, to avoid the medical legal problems later.
So while preparing the endometrium for embryo transfer in these group of RAF patients, where it is true RAF, as you were telling us, true RAF is only 5%. In some patients, we'll find some evidence of chronic endometritis, or there will be some reason why the implantation has not occurred. So in those true cases of RAF, is one protocol superior to the other? For example, modified natural cycle transfer or only a hormone replacement cycle, which is better, sir, for replacing the embryos?
Of late, instead of the hormone replacement, other things all like that. When you are doing now with the natural cycle, like true natural cycle, that is particularly, that is better. Pregnancy rate is improving. So sometimes it will be very difficult. We don't know when it ruptures, when we have to like that. It may come on Sunday or you may go out like that. There, and if you go for the modified nature also, that is better than going for the suppressed cycle or the hormone replacement therapy.
Sindhu, can you just take the answers to the poll so that we can ask some more questions a little bit after the poll? Is everybody done? You're not audible, Sindhu. Your mic is switched off.
Sorry. Around 50% participated, ma'am. I'm displaying the answers now. So the first question, women who smoke are associated with the following except. The correct answer is increased aneuploidy rate, and majority have answered that, 42%. Assisted hatching may be clinically useful in patients except. The correct answer is all frozen embryos, 45% have answered that. Diagnosis of chronic endometritis infection by immunohistochemistry staining is said to be positive when the following is present. The correct answer is CD138. Majority have answered that. What is the first drug of choice to treat chronic endometritis? Doxycycline is the correct answer. 58% have answered that. What is the magnification of IMSI procedure of sperm selection? Answer is 6000x. 42% have answered that. So, very nice. Thank you all for your participation.
Thank you so much. Sir, you were mentioning about intrauterine adhesions, and when we see adhesions with cystoscopy and adhesiolysis, suppose we do the adhesiolysis, should we wait for 3 months, give cyclical estrogen progesterone, or put a inert IUCD, and then do the embryo transfer? How long should we wait, sir?
That depends upon the severity of the additions. So it is minimal or mild like that is not going to do anything. If it is more than that, then we will be using so many other barriers like that. But each person's nature, the body nature is different. Some patients, they won't form any additions at all. Some people, whatever you do, anti-addition therapy, precautions you take, there will be forming. But second look lab hysteroscopy you can do. If there is anything is there, that also you can remove like that.
Okay, sir. And sometimes we are perplexed with minimal fluid in the endometrial cavity, sir.
Yes.
So in those scenarios, we have ruled out all pathological causes for fluid in the cavity, infections, chronic endometritis, and hydrosalpinx and everything. Okay. And we also try to modify and change the protocol. Maybe we can, transfer in a modified natural cycle or something. Despite that, we see sometimes. So in those scenarios, should we go ahead and take preventive clipping of the tubes? Is that recommended, or should we just aspirate and transfer, because it is a very difficult situation for us?
Yes, see, whatever all the investigation you are doing, if it is coming negative, so just if you see that one, aspirate and transfer like that, patient will mostly they will conceive actually. No need for us to go and clip the tubes if there is no hydrosalpinx is there.
Thank you, sir. So now a lot of new drugs are coming, sir, like thymosin alpha and all those things in recurrent implantation failure. So many companies are coming because this was used predominantly in the COVID storm, sir, to suppress the immunological storm basically. And they have extrapolated that into recurrent implantation failure. And also a lot of people are doing immunological testing, whether it is uterine immunoprofiling or something like that. Though the evidence is saying research setting, should we, attempt and do it in certain cases at least? Sometimes we would have faced euploid embryo transfer that has failed. We really don't know what is the reason.
That's what I told you already. Whatever drug is there, if nothing is available, if it is not going to harm the patient, discuss with the patient, and if she is willing like that, take consent, then we can try. See, with that, I didn't have any experience with the thymosin, even though they have given some paper that is going to help like that. We need some time to get the more answers for that. Then only, like we can say, definitely it is going to be useful for every patient to use. But we can. One more thing, my policy is by seeing one paper, I won't just like that jump into that one. No, say I'd go like that. I will start using that drug on my own. Even if it's 10 patient, 20 patient, you will know how it is, whether it is working or not, whether that conclusion is correct or not. Then only I will take that, whether I will start using. Because somebody is coming and telling I won't use, by seeing one paper, no, just I won't be using. That's what my advice is for everybody. It is like that. You are doing daily cases, you do 10 cases, 20 cases, just you give and see. If it is going to work, definitely we are going to continue the treatment.
So somebody has asked, what are the indications for intralipid in case we want to use intralipid? What are the indications to use intralipid?
Only recurrent implantation, still we are going for things. So like we have used in Ramchandra, some patients, that patients all almost more than 60% pregnancy rate has come like that. Definitely, I won't say you give to everybody. We are just trying like that. It is coming.
And once the pregnancy is positive, it is continued till 20 weeks, sir?
Yes.
So same thing with atosiban as well, sir. Does it really help in implantation failure?
See, the idea is one of the reasons for the not conceiving is that uterus is overactive. That's why it is expelling that embryos. That is the thing. So studies also say the main problem is all single papers, what they are coming, the limited number like 10 patients, 20 patients like that, that is all giving there is favorable report. But if you take the Cochrane review, it says there is no, the evidence is low evidence. That is the problem. That's why we need RCTs with the bigger sample, then only definite I can say. I am not using the atosipan like that.
I think, sir, has already answered, but one of the delegates has asked HLA sharing which patients it is indicated. I think, again, it is matter of, having more evidence and more testing. And what are we going to do if you're going to have HLA sharing? Are we going to avoid those embryos? How are we going to screen the embryos without sharing? Or are we going to advise surrogacy? It is a whole lot of discussion and we need more evidence. Correct, sir?
Yes. That's what, like, nothing is available. The one thing is, one is, I didn't want to tell anything. Okay. The problem is, now we told you like now already, like gamete change and like surrogacy. That is the only final option is available. That's what, like, if you are suspecting, that is the problem like that. That we have to change. That is last resort. Nothing is available like that. Then we can try it.
So, and heparin also people are using for immunomodulation, this thing, just like how you said about aspirin. Can heparin be added routinely in all RS cases, or most of us add that? Though evidence says against it, I think most of us do add this in practice.
Yes, see, if you are going to use the conventional heparin, there the monitoring is important. The complications, other things are more. But if you are going for the low molecular weight heparin, it is very less. No need for us also, man. That also discuss with the patient. If she's willing like that, then you can give like that. It's not, see what we are going to give like that. Suppose at 14 days you are going to give. Once the test is coming as positive, then you will discuss and continue like that for some time. Otherwise, that 14 days is not going to create any problem.
So, what I understood is the embryo is very important. It should be a euploid embryo, and then the endometrium should be good. And despite all these measures, and what blood investigations should be done, sir, in a patient of RAF? I mean, which we should do at least any APLA testing, antibody testing, TPO antibodies, anything that has to be done, sir?
If you want to exclude everything like that, then we have to go for that. APLA, other things, anti-nuclear antibodies, all those things we have to do. Otherwise, there are one patient has come from US. You have to see like that. There are 50 tests they have done. There are so many things are there, but I don't know what is that things. Maybe after some time they are going to add some more tests. How much it is going to help like that, we are not sure.
Thank you so much, sir. Thank you so much for your time. And you've been talking so much for the last 1 hour. I think we should give you some rest. Sindhu, can you just take over further?
Thank you.
Yes, sir. Thank you so much, sir, for giving so much of your time and patiently answering all the questions. It means a lot to us for you for accepting us and presenting here. Also, with this, I'd like to announce that we have two masterclasses. One is embryology masterclass, which happens in the first Thursday, and advanced ART masterclass, which sir has started now. It will happen in the third week every month. So next month, April 3rd, we have masterclass on IVF and ICSI by Dr. Gaurav Majumdar. And on April 17th, we have advanced ART masterclass, endocrinology of stimulated cycles by Dr. Sachin Kulkarni. So I once again thank Sanjeev Reddy sir for your time and for all your inputs and expertise, and all the delegates, and Vasundara ma'am for organizing this, and all the senior experienced members who still want to learn from Sanjeev Reddy sir.
Thank you so much, all the delegates, sir. Please accept our gratitude and thanks, sir, for starting this masterclass series in Advances in ART. Thank you so much, sir. Thank you, all the delegates. We request you to please kindly share the feedback which is being posted in the chat box. It will help us to improve and do better in future. Thank you so much, sir. Thank you, Sindhu.
Thank you, ma'am.